I mean, it's just a formal thing to just welcome Professor Jeffrey to this webinar, and Dr. Paul. It was nice
Thanks.
that he has joined us. So I think we'll start the program. So
Yeah.
it'd be very interesting to listen to him, the nuanced decision-making and IONM principles, practice, and pitfalls. Sure.
Sir, can we have a statement from Dr. Paul, the Executive Director of AIIMS Patna, because about 260 physiologists have registered for the conference. It'll be great to meet sir and have his opening remark.
Yeah. So, am I audible now, Nishant?
Yeah, sir, very clear.
Yeah. So, good evening, all of you. Greetings from AIIMS Patna. I am really delighted to see that the Institute of Neurosciences, SIMS Hospital, Chennai, is organizing a very interesting and useful workshop on nuanced decision-making in IONM under the dynamic leadership of Dr. Nishant Sampad. Nishant, I know he's one of the best IONM specialists in the country, and I'm so happy to know that the main expert, Dr. Jeffrey Balzer, who has so much of experience and expertise in this IONM, will be playing a leading role, and I'm sure all the participants will be highly benefited by this IONM webinar. All my best wishes, and I congratulate the entire team, and I congratulate Dr. Nishant for organizing such a beautiful workshop. All my best wishes.
Thank you, sir. Thank you so much for finding time in your busy schedule. When I visited Patna, I saw how busy you were, and you had meetings at 10 p.m. on a Sunday. So thank you so much. And I can see that you're still sitting in your director's chamber. And the first of its kind DM course is real, master stroke. And thank you so much for doing that for the Physiologist Society, sir. And
thank you, Nishant. Thank you.
Yeah, we have Dr. Suresh Babu, one of the pioneers of modern neurosurgical practice in the country, and he has mentored plenty of neurosurgeons who are doing great work. And let me, introduce the speaker. The speaker, Professor Balzer. I met him when I was in Pittsburgh to deliver a talk. And I must say that he's one of the most passionate neurophysiologists that I've ever met. His discussions are pretty thought-provoking, and in any kind of international neurophysiology meetings, you cannot have a meeting without Professor Balzer's talk. So if you have been following, the previous two webinars have been pre-recorded, but I know the kind of energy that Professor Balzer bubbles with. So I wanted this to be live because, the Indian audience will be so much benefited by seeing him live through his, very thought-provoking discussions. So Professor Balzer has experience of over 30 years in the field of IONM, and he was former president of American Society of Neurophysiological Monitoring, and he's one of the sitting board members. And he has authored over 130 articles in IONM, and has authored about 19 book chapters, and is one of the co-editors of one of the reputed journals, the Neurodiagnostic Journal for Neuromonitoring. Is the director of clinical services of Center for Clinical Neurophysiology Lab in UPMC, and is also the director of Cerebral Blood Flow Laboratory. I had the privilege of meeting him in his own lab, and there were plenty of 3D printed models for aneurysms and so on. And to give you a perspective of what clinical operations, director of clinical operations, is that they do about 8,000 surgeries a year. And he has about 60 to 80 techs, certified techs under him. He is in charge of their education, the quality control, the workflow, man management. And they not only take care of UPMC group of hospitals, they cover about other hospitals which are within about 100-kilometer radius from UPMC. So this is what, just a brief introduction that I can make for Professor Balzer. So rest, I think it's over to you, sir. Thank you so much for generously accepting our invitation to be delivering this lecture.
Well, Nishant, thank you very much. It's quite an honor to have the opportunity to speak to your group in India. As you suggested, we've been doing this for quite a long time, and I think what you'll find from my presentation is a composite of what we've learned over those 30 or 32 years in terms of what it takes and what makes a good intraoperative monitoring service. And I think that most of that is reliant on an open line of communication between the neurophysiology team and the surgical team, and that everybody's on the same page. That as a neurophysiologist, I need to be able to understand the neurosurgical procedures that are being performed and the nuances of those. And the surgical team needs to understand the neurophysiology, and that we're both speaking the same language. Because when changes occur in intraoperative neurophysiological monitoring, and I'm going to show you some examples of this, we know that they're diagnostically accurate. We know that those changes are a reflection of a compromise in neurological function. And it's our only way to know that because the patient's generally anesthetized. But once that is recognized, that's when the real work of the neurophysiologist and the interaction between the neurophysiologist and the surgeon begins. And that's trying to figure out what can be done or what may be done to mitigate a poor outcome or prevent a poor outcome. And I think the best way to exemplify that, and the way I'm going to do that, is show you what the model is, but then go through some cases, right? I think running through some specific examples of interventions and interpretation of the data and those nuances would be most helpful. So thank you very much again for inviting me. I hope my talk is informative for you all. So I'm going to focus on first describing the advantages of using intraoperative monitoring, and I'm not going to spend a whole lot of time on this. Describe the ION model and how it can be effective, and I'm going to spend a little bit more time on this because I think this is really important. The model and how the intraoperative monitoring is integrated and executed is really what can make it effective in the operating theater and best serve the patient. I'll describe the various modalities we have at our avail and how they fit into the monitoring algorithm. I'm not going to spend a whole lot of time on that because everybody sort of realizes that. The IOM application for neurological surgery, and then I'm going to go through some case examples, all of which really require thoughtful consideration of the data to help us develop an interpretation and subsequent recommendation for the surgical team. And as I said, this really requires a knowledge base that's important for the neurophysiologist to have. Intraoperative neurophysiologist has to be thought of as a peer-to-peer intraoperative consultation. And if it's not thought of as that, then it doesn't work, right? Everybody needs to be on the same page. I'll talk about the implementation of a checklist approach for all cases utilizing IOM that we and others have proposed. And that's really important because when you do see a change in the intraoperative monitoring, you want to have some flow and algorithm of what you follow. So let's kick it off by talking about the advantages. Obviously, with intraoperative monitoring, the surgical team can detect problems that are occurring in a generally anesthetized patient. And as a consequence of understanding that something's changing in a neural axis, they can reduce and prevent permanent damage. Depending on the circumstances, the intraoperative monitoring can truly provide an early warning system to detect impending neural injury. So the bottom line is that if we see changes in intraoperative monitoring, it's not too late. It's the difference between them being predictive and preventative. If your alarm criteria is set where every time you see a change, the patient's going to wake up with a new deficit, then you need to change your alarm criteria, because at that point it's not preventing anything. It's just predicting a poor outcome. Once we see these changes and they're detected in a timely fashion, then we can take measures to mitigate or prevent central nervous system problems from occurring. So the intraoperative team, as I said, neurosurgical procedures generally performed under general anesthesia. As a consequence, there's no way to reliably assess all the different neurological statuses of the patient. So we like to think that the intraoperative monitoring actually acts as a real-time surrogate or a biomarker for changes in neurological status. And that's an interesting way to look at things. And I'd say that probably the past dozen or so papers we've published across the spectrum of neurosurgical procedures we've begun to call IOM a biomarker. And you know, if you think of biomarkers as like BMI is a biomarker for obesity, I think IOM is a biomarker for significant change in neurological function. And so if you're able to measure a biomarker, then you should be able to index what's changing in the patient and potentially intervene and change the outcome. So how does it work? So obviously we all know this, IOM generates this, and we're able to measure electrical impulses. We put electrodes on the patient's wrist, scalp, along the entire neural axis. And what we're able to do is we're able to record ascending and descending signals that are a reflection of sensory systems, motor systems. In the case of EMG monitoring, we're able to measure cranial nerve EMG function and spinal cord root function, et cetera, et cetera. And if we do see changes occur, the neurophysiologist is meant to immediately alert the surgeon, and if necessary, have a consultation about appropriate intervention. So what's the team in this thing, in intraoperative monitoring? So the team, and when I say team, this is really an important aspect of intraoperative monitoring that makes it work well. The team is composed of the surgeon, the clinical neurophysiologist, the anesthesiologist, and the nursing staff. And everybody needs to be on the same page with regard to what each individual's role is and how how the roles of each individual can overlap, and how that's really important in surgical procedures. I'm not going to spend a whole lot of time talking about anesthesia today, but you know, it can't be lost that the fact that, you know, anesthesia plays a very important role in the success of intraoperative monitoring, because oftentimes, you know, anesthesia can prevent us from measuring good signals or measuring signals at all. So everybody needs to be on the same page. The clinical neurophysiologists need to have training and experience, obviously, in the general field of clinical neurophysiology. And this includes an in-depth knowledge of evoked potentials. But I think this last statement is really important. They also have to have a knowledge of anesthesia and neurosurgery. So when I first started here in 1992, the first thing I did as a fellow is I used to go to the operating room every day and watch the intraoperative monitoring being done. And then I used to go to the residence library, the neurosurgical residence library, because my faculty position's in neurosurgery. And I used to read neurosurgical textbooks because I had convinced myself that in order for me to make an interpretation about a significant change in intraoperative monitoring, I need to know what you guys are doing. I need to know the procedure. I need to know every step of the procedure. I need to know every instrument you're using. And I'm convinced that the higher level provision of intraoperative monitoring is delivered by everybody understanding what each individual is doing in the room. So if I don't know what you're doing surgically, or have a good idea of what you're doing surgically, then my information I'm going to pass on to you can be lost. You know, one of the jokes in our department is that I could probably pass the neurosurgical board because I read so much about neurosurgery. The fact of the matter is I couldn't do a surgery because I've never been technically trained to do it, but I certainly know every single step that occurs in most every neurosurgical procedure, and it's paid dividends for us. The neurophysiologist interprets the changes during the surgery. We offer a differential diagnosis, and that's based on what was going on during the surgical procedure, how the data changed, what the anesthesia is, and as a consequence, we can make potential therapeutic interventions and suggest those to the surgical team. So in essence, you know, intraoperative monitoring constitutes the practice of medicine on the part of the neurophysiologist, because as I said, they are then part of a peer-to-peer consultation in the operating room. The surgical team can then use the real-time feedback to evaluate how the CNS is responding, and this can ensure that neurostructures aren't being violated during these procedures. So quickly, what are some of the modalities that are to our avail during these procedures? I'm not going to get into the weeds on any of these, but I do want to mention them. Somatosensory evoked potentials, which can be used as more of a continuous measure. Motor evoked potentials are exquisitely sensitive, are exquisitely diagnostically accurate, but they do have one potential pitfall in that delivering the stimulus for a motor evoked potential can result in patient movement. So it's not a continuous measure of descending motor function, depending on how it's used. We should always be aware that that we should do these as often as we possibly can during these procedures. Brainstem auditory evoked potentials are invaluable in post-fossa surgeries where the auditory nerve is at risk. As I said earlier, I was hired by Peter Janetta, so I was here during the rise of microvascular decompression for things like trigeminal neuralgia and hemifacial spasm. So we have a very, very big experience with brainstem auditory evoked potentials. Visual evoked potentials, quite frankly, really weren't done a whole lot in the operating room when I first came here, but they're actually gaining some traction. I think that the popularity of doing visual evoked potentials is based on, number one, obviously preventing injury to the optic nerve and chiasm, but also the optic radiations and primary visual cortex. The problem with VEPs was the reliable delivery of a stimulus to the eye and false positives in those cases. But I think we're getting better at doing them. EEG is a modality we use quite a bit. We use that typically in conjunction with SSEPs and MEPs. We use corticobulbar motor evoked potentials in cases, which are a very nice measure of cranial nerve function that act as a more continuous measure of that, rather than picking up a monopolar and stimulating the seventh nerve, picking it up and stimulating, picking up and stimulating. We do phase reversal. We do cortical and subcortical mapping during a variety of glioma surgeries. What we've learned over the past 10 years is the last thing you want to do is take a patient, for example, as a GBM, and we know that gross total resection is the best in terms of survival for those patients. But if you hurt them during resection, then it actually reduces their survival length. So you want to do the best operation you possibly can do, but you want to do it as safe as possible. And that's what the cortical and subcortical mapping allows. So this is the algorithm that we abide by. So I've reduced everything I just said to one slide. So we perform all of these modalities. The important thing about the first thing that's most important is that these modalities are diagnostically accurate, and any change in these modalities is truly a reflection of something changing in the patient's neural axis. The last thing that we want to have happen during intraoperative monitoring is a preponderance of false positives. And that's for two reasons. Number one, we want to make sure that we're able to accurately identify change. But number two, if you want to lose confidence from a surgeon when you're doing intraoperative monitoring, then have a bunch of false positives. It's the quickest way for them to lose confidence in what you're telling them. I've always said that, people think that false negatives are the bane of our existence, i.e. missing a significant change and a patient waking up with a deficit. I think that happens. I think it happens in every aspect of medicine. What we measure doesn't measure absolutely everything, but the bane of our existence and what hurts the reputation and the intraoperative monitoring team the most are false positives. We don't want to be jumping up and down every 2 seconds in an operating room, telling the surgical team that something's changing when it's not significant, nor is it something that the surgical team could potentially address. So that's really important. once we know the diagnostic accuracy, and I'll show you innumerable examples of that we've published out of our institution, then you have to recognize change. And recognition of change is really based on having a formidable and accurate alarm criteria that says, hey, I'm seeing something changing, but it's not quite to the point of where I think it's significant yet. So establishing alarm criteria based on the literature and based on your own experience is important. Once you see that significant change, interpretation is important. So it's my job as a surgical neurophysiologist to run through an algorithm in my mind. Is this surgical? Is this anesthesia? Is this the patient's blood pressure? And what we do at UPMC is, until we decide that the interpretation of a change in data is something that is attributable to this happening in the surgical field, the last team we talk to is the surgeon. We try to intervene at every place before that because you're doing surgery. You're worrying about the patient at that point. And if I can talk to anesthesia and say to anesthesia, hey, can we increase the map by 24? That makes the responses better. Then you go on about what you're doing there. Now, if I talk to anesthesia and raising the map by 24 doesn't result in a betterment of the responses, then I loop you in to what we're thinking about then. But we try to not involve the surgical team up front as much, because you're doing what you're doing, we're doing what we're doing. When I always laugh here, surgeons tell me that when I walk into the room and start talking to them, they're worried because they know that something's very wrong when I'm in there talking to them that can't be addressed otherwise. Once we make an interpretation, we can propose reasons for how to reverse that change we're seeing. So everything up to this point of reversibility is really based on the IOM team. Once information is provided to the surgical team about a recognition of change, what we think caused the change, and what might be done to potentially reverse the change, the last point is consideration. And consideration is where the intraoperative monitoring goes from being the responsibility of the IOM team to the responsibility of the surgical team. But that responsibility of the surgical team and the consideration they give the monitoring is exquisitely dependent on all these other things that happened before that. In other words, if I tell you I'm seeing a significant change in the motor evoked potential, my interpretation of that is I'd like to increase the mean arterial pressure, and if that doesn't work, it could potentially have been, I don't know, in a scoliosis case, it could potentially have been derotation of the spine. And my suggestion would be to potentially remove a rod and see if the responses come back. Then the onus is on the surgeon to either adopt or not adopt what they're being told. But this adoption, this consideration, is based on the trust and based on the competence of the intraoperative monitoring team that has performed the intraoperative consultation at the time of the change. So there was a paper published several years ago that I think is actually a very good paper, where they looked at intraoperative monitoring alarms, and they looked at the relationship of the surgeon's decision to intervene or not intervene, i.e. consideration, and clinical outcomes in a subset of surgical patients. And what they found in this study was that significantly more patients recovered by the time of discharge when a surgical intervention was precipitated by an IONM alarm. In other words, the monitoring works if you can and do give it consideration. But again, this is really dependent on the confidence you have in the intraoperative monitoring team, their training, et cetera, et cetera. Very briefly, I'm not going to go through a whole lot of this because I got plenty of cases we can talk about. SSEPs, we know that that's ascending dorsal column function. Motor evoked potentials, descending lateral spinal cord function. One is not appropriate, more appropriate than the other when you're doing spine surgery, because unless you're doing both, you're not covering or you're not assaying the entirety of the spinal cord. And there are case reports in the literature where you can have patients who wake up with pure motor deficits or worsening motor deficits in the absence of SSEP changes. And those are typically vascular changes involving segmental arteries, artery of Adamkiewicz, et cetera, et cetera. So those vascular structures that are respecting the lateral or anterior side of the cord. So our recommendation in these spine cases, for the most part, is to do multimodality monitoring. Brainstem auditory evoked potentials we talked about, visual evoked potentials, as I said, you can see from this picture. The real challenge in this is delivering an adequate stimulus to these patients and making sure that it's being delivered well throughout the whole procedure. EEG uses an adjunct in a number of these procedures, mostly for detection of ischemia. You can also use EEG for as a surrogate for anesthesia depth. And while it's not a absolute, what we do know, and one of the reasons we do EEG in spine surgery is if the EEG begins to become more and more burst suppressed, we know that that makes it more and more difficult for us to get motor evoked potential. So it's a surrogate of other measures we're making. EMG, I mentioned this, we can do EMG of the cranial nerve, we can do EMG of the cervical, thoracic, and lumbosacral nerve root. So what about applications in neurosurgery? That was a very brief introduction. I think everybody understands that. I want to make sure that going into these cases, the take-home point so far is the team approach and the competency of the team and the team being on the same page and trusting one another and accepting that what we're doing in an operating room is consulting. No different than if you saw a patient, one of your patients having a seizure in the ICU, you're going to call neurology for a consult, and they're going to do an MRI and an EEG, et cetera, et cetera. That's happening and could be happening in real time in the operating room for there to be effective application of intraoperative monitoring. So I'm going to try and show you some examples of that in these cases. These are interesting cases that I've done over the years. I'll do some spine. We'll talk about a cranial surgery. If we have time, we'll do endovascular. We can do vascular surgery. And I could go on for hours here. Nathan said I don't have hours. But we do 8,000 cases a year. So we've got plenty of cases where we see change and that we are able to intervene and have formal discussions with our neurosurgical team. So let's talk about spine surgery. So as I mentioned to you, first and foremost, the diagnostic accuracy and the techniques we use to monitor spine surgery have to be ratified and we have to know that when these things change, then we have a problem. And, our group here has published over the years looking at scoliosis and SSETs. We've looked at multimodality monitoring. We've looked at pedicle screw stimulation and lumbosacral spine. We've looked at, as I mentioned earlier, a localization of spinal column stimulators. We'll look at monitoring during cervical surgery, both anterior and posterior, and looked at patients with radiculopathy versus myelopathy and how the monitoring changes in those cases, using multimodality monitoring in lumbosacral spine surgery. I published a multi-center paper with Juan Uribe, who's at Barrow, looking at the efficacy of doing EMG during transpsoas lateral approaches. We've published data on the risk factors of just positioning patients in spine surgery and how the monitoring is very useful there. We also recently published a paper looking at the diagnostic accuracy of deficits in thoracic fusion and decompression, triggered EMG again. And these are a couple of papers that have recently been published outside of our group that have shown that if you detect a change and you intervene, these patients do better. This paper was published by Dr. Willent a couple of years ago, looking at motor evoked potentials in lumbosacral cases, and by the same group, looking at monitoring of MEPs in cervical spine surgery with a significant reduction in deltoid nerve palsy by intervening when you see a change. So these papers are out there. I think the data is getting better and better with regards to proving that if you can diagnostically, if the modality is diagnostically accurate and you can detect a change in a timely fashion and consult with the surgical team, then you can help these patients wake up better. I added this because this was just published by the North American Spine Society, where they looked at a large database. And, you know, in the United States, and I'm sure this is in India as well, cost is a big factor for anything, spine surgery, monitoring, et cetera. So this was just published by the North American Spine Society, and their conclusions from a big analysis was the use of IOM in spine surgery is cost effective in almost every scenario they examined. And basically what they said was doing monitoring in these cases is a value add for not only the patient, but also from a cost perspective. In other words, the cost of doing monitoring is far less than the cost of having patients wake up with new deficits that could have been prevented by performing monitoring in those cases. Okay, so let's talk about the fun stuff, some case examples. So case one, 53-year-old male presents with a left foot drop and has some radiculopathy, but otherwise is intact. And I think it's remarkable that it's intact once I show you a scan. So his imaging demonstrates an L5 spondyloloptosis that's progressed over the past 5 years. I've been doing this for 32 years. I've probably seen a half a dozen of these, so not a common thing. So you can see an L5 S1, he's completely off, completely off. So this is S1, this is L5. This bone right here is the top of the L5 lamina. This is the L4 lamina that's back here. So the planned procedure was an L5 decompression via gill procedure with a laminectomy and left-sided metafacetectomy and foraminotomy at L5. So the operation was to address his foot drop, essentially, and get as much correction of that slippage as possible. So the plan was to do an L3 to S1 instrumented fusion, potentially extending the fusion to the pelvis, and obviously an arthrodesis. We used computer-navigated neuronavigation for planning and placement of pedicle screws. In this case, the surgeon asked for SSCPs only in this case, which, you know, as a surgeon, right? I think it's really important for you to have a conversation before the case begins with the neuromonitoring team about which modalities are going to best be served for the patient. And the reason I say that is, you know, there are people out there in the United States anyway who tend to do what I call the kitchen sink approach. They do every modality they possibly could do. And while that sounds great, I think it can add a lot of confusion in these procedures. My approach to the intraoperative neuromonitoring is to do the modalities and perform the modalities that are most indicative of potential morbidity in these cases, right? And those that allow me to, in fact, make an interpretation of the data. So, for example, if I did visual evoked potentials in this case, and they changed, and you said to me, well, Dr. Balzer, what does that mean? I'm going to look at you and say, I have no idea what it means. So I never want to say that during a case. I always want an answer for the surgical team about what I think the change means in the context of what's going on during the procedure. So what was the event? So they were putting screws in on the left at L5, and what they noticed was there was motion at the L4 and L5 S1 segments. So as the screw was going in, that spondyloloptosis went like this, briefly. What we found was that there was a left-sided lower extremity SSDP loss, followed by a significant decrease and insignificant loss of right-sided lower extremity SSDP. So, before I show you the data, here's where my job begins. So earlier in this case, we had a change in our SSDPs that we attributed to, well before they were doing anything surgically, that we attributed to an increase in the gas that was being given, sevoflurane. So when this change occurred, I came to the room and I asked the technologist what was happening, and anesthesia came over to me and said, hey, you know, I know that you had changes earlier. We were changing the CO2 scavenger canister on the anesthesia machine, which can cause a backup or increase of the gas. So it might be the gas again. So I walked over to the table where the surgery was happening, and I looked at the surgeon in charge, and I said, well, anesthesia is telling me that this could have been a gas problem. What do you think? Well, that's when he told me, and again, this is why it's so important to be forthcoming with surgical information. This piece of information, that when they were putting the screws in, there was some movement of the spine. So I said, okay. And I actually turned around and started to walk out of the room. And I thought to myself, I don't think this is the gap. So I walked back over to the table and I looked at the primary surgeon and I said, I don't think this is the gap. So here's the data. So this is the left median nerve SCP, the right median nerve SCP. These are all cortically recorded potential. This is the left tibial nerve SCP and the right tibial nerve SCP. And you can see that they just go away, completely disappear on the left. They hang in there a little bit more on the right, but they go completely away at this. So what happens now? So I decided, and I told the surgeon that I don't think it was attributable to the gap. Here's the events that occurred from that time on. So we told the surgeon about the left side being absent and the right side being decreased. This is where my interpretation and my suggestion of intervention occurred. I went over and I looked at the scan again. And after reviewing the scan and the MRI, I suggested to the surgeon that the problem was the movement of the spine, but the culprit was the L4 lamina that was above. And my suggestion was that we raise the mean arterial pressure. This was 11:20, shortly after the change. Raise the mean arterial pressure and perform a decompressive laminectomy one level above where they were planning on doing it. So it became clear at that point to me that the L4 lamina was causing severe thecal sac compression. The primary surgeon came over to the viewing, the computer looked at his scans with me. He agreed, and they started an L4 laminectomy without a facetectomy to decompress the cauda equina. Because to have a bilateral pain in the cauda equina, remember, you're not over the spinal cord, you're over the thecal sac. That would have to have meant that there's a significant amount of bilateral compression of the thecal sac. Once we started to decompress and finish the laminectomy, the responses came completely back to baseline after the laminectomy was completed, and the patient woke up with no neurological deficits whatsoever. So this is a classic example of diagnostic accuracy of the data, having a conversation with anesthesia, having a conversation with the surgical team, reviewing the scan, the neurophysiologist having the background and understanding of what was going on surgically, how to look at an MRI, how to look at a CT scan, and make a suggestion about a surgical intervention. And most importantly, perhaps, is the surgical team having the confidence in the neurophysiology team about what the intervention might most help the patient in this case. And that's really important. So fortunately, this patient woke up at his neurological baseline, and quite frankly, his foot drop actually improved several weeks later. Case 2, 55-year-old female with polytrauma who was neurologically intact after a motor vehicle accident. She did have radiographic findings at T2, at T3, and at T4, despite the fact that she was neurologically intact. She did have quite a bit of polytrauma in her thoracic spine. So here's a picture of her scans, and you can see that she has this kyphotic deformity. At T4, she's got a significant decrease in the height of her vertebral body anteriorly, and she's really draped over this deformity. So the procedure we were going to perform was a posterior spinal fusion from T1 to 7. We got pre-positioned baselines in this case, which I can't tell you how important those are to get, to understand what you're dealing with neurophysiologically before you position a patient that has this kind of deformity. Because, once you position that patient prone, that kyphotic deformity, particularly if the patient's relaxed, wants to correct on its own. So you want to make sure that you're not compressing the cord before, after you flip them over. So that's why pre-positioned baselines are so important. We decided to do SSEP and MEPs in this case. And we also noticed, and I don't have an axial film here, but we also noticed that the patient had very tiny pedicles throughout this thoracic region. So here's our baseline. SSEPs on the left, left upper extremity SSCP, right upper extremity SSCP, left lower extremity SSCP, right lower extremity SSCP, and beautiful motor evoked potentials from the upper and lower extremities bilaterally. So we're placing screws on the right, and what we see is an isolated MEP change. So again, as a neurophysiologist, what I always do, and what you have to begin to say to yourself is, how does that happen anatomically? How can you get an isolated change putting that screw in, right? So you have to think about the trajectory of the screw, what it would take for a misplaced screw to not affect the dorsal column and only affect one side and not the other side. In other words, this looks like it could be like a Brown-Séquard syndrome, right? Where the screw only affected the right side of the cord. So we immediately told him we did not ignore this, despite the fact that everything else looked just on baseline. And that's the other thing that's important in this case as well. As a neurophysiologist, you can't write this off as a non-significant event, right? Instrumentation's going in, it's going in on the right, you lose the right motor, and despite that nothing else changes, you can't say, maybe it's nothing. So we told him right away. So what do we do at that point? What was the therapeutic intervention? Well, we have a checklist, and I'm going to share that with you in a bit. What this surgeon did, he was a junior attending at the time, is he consulted one of his senior partners. And his senior partner came into the room, they completed this case together, they omitted that screw that caused the change when they were putting it in. We woke the patient up, and they had right lower extremity weakness and decreased sensation. So that was clearly diagnostically accurate for this. And their changes where the motor exam was worse distally than it was proximally. They admitted the patient to the ICU. They completed the hardware. Last seen is 6 months, and they're actually getting much, much better, and their sensation is back to baseline. So you say to yourself, well, what good was the monitoring here? Well, what good was the monitoring here is, I would argue that if you don't take that screw out and you don't finish this procedure and make sure all these other things are important, increasing the blood pressure. If you see here, admitted to ICU for MAP control, right? Not only did we consider their mean arterial pressure in the operating room, that followed the patient to the ICU afterwards, right? Having a floor MAP in this patient is important. The last thing you want this patient to do is become hypotensive in the ICU, because it could worsen their neurological changes that we saw in the operating room. So once again, this is a win for intraoperative monitoring, but it's also a clear example of the surgeon taking grave concerns about what he was being told by the neuromonitoring, and not just saying, come on, how could that possibly happen? Everything else is on baseline. So it takes a surgical team to believe what they're being told by the neuromonitoring team, and the neuromonitoring team having the confidence into identifying what the changes were. Case 3 is a 79-year-old male who presented with polytrauma, again after a motor vehicle accident. He's got a T2 fracture dislocation, discal ligamentous injury at T4-5, and he was already kyphotic. So bad scan, right? I look at this scan as a neurophysiologist pre-op, and it's like, I stutter, right? So I start running through my head, where's the potential for injury to this patient? And as far as I'm concerned, it starts before incisions even being made, right? I think about the patient's blood pressure. I think about the patient's position during the surgery. I think about pre and post position baselines. And if your neuromonitoring team is doing what they should be doing, they should be thinking that for you, doctor, surgeon, because that's where their value add is, right? That's where they're coming from. So we did C3 to T6 posterior spinal fusion. Once again, we did pre and post position baseline. We did SSEPs and MEPs, and as you can see, the patient has a huge, rigid, pre-existing kyphotic deformity. So one of the other things that I will ask the surgical team in a case like this, right? And it's such an important question. And it sounds like a dumb question, but it's not. My question would be, what's the surgical goal in this case? And the reason that's such an important question from a neurophysiology perspective is if you say to me, which was the case in this particular surgeon, is all we want to do is get this guy stabilized. we're not worrying about correcting his kyphosis, right? That changes my entire mindset about what the potential for changes are in this case. So this doesn't become like a Sherman's kyphosis case where, you want to take that deformity in. This is all about this stabilizing the patient, which is important. So one of the things that I mentioned already is thinking about other things that could cause changes. So here's our data: left upper extremity, right upper extremity, left lower extremity, right lower extremity, and our motor evoked potentials look great. Doesn't surprise me, the patient's intact. This is an important picture. It's going to tell part of the story of this surgical procedure. So this is a photograph of the patient on the table. So you can see he's in a tremendous amount of Trendelenburg, and he's connected to the table by Mayfield head pin. Okay, and you can see he's on rolls, but he's at probably a 60-degree angle from the floor. So intraoperative surgical event. We're placing screws. SCTPs look good ×4. All of a sudden, the lower extremity MEPs become significantly variable. They're there, they're not there, they're there, they're not there. And remember, we're placing screws. So once again, I started to run this checklist in my head. How could screw placement cause the motor evoked potentials to become labile or variable? And it's hard to imagine that. So obviously we check the mean arterial pressure, we run our list, we check the screws, and then the lower extremity SCTPs also begin to change, which becomes very concerning at that point. So we ran a checklist and all the screws looked fine. Ultimately, they consulted me and they consulted a senior partner who was a senior orthopedic partner who was also doing this case. Well, fortunately or unfortunately, having done this for 32 years, there's not a whole lot I haven't seen in the operating room. And the senior partner who came in, we looked at one another and we said, we've seen this before. And we thought that this change was due to this, the positioning of the patient. So what we had seen in a previous case is the patient, despite the best job we can possibly do, began to slide down the bed while being connected to the Mayfield at their head. And what that does is that, by de facto, begins to put pressure on a kyphotic deformity. So we thought that this change that we were seeing had nothing to do with the surgical procedure and everything to do with the positioning of the patient, and now the change in the position of the patient. So what did we do? We undraped the entire field. We repositioned the patient, moved them up on the bed, made them a little bit flatter. The MEPs improved, and the SCTPs, despite a little bit slower, also improved. We completed the case. The two surgeons completed the case together. We did an awake exam at the end, and the patient was completely neurologically intact during the procedure. Went to the ICU, and a couple months later was 5 out of 5. So once again, you can't. Remember early on I said you can't always look at what's happening surgically in these cases, but when you have to enlist the help of the surgical team for a reason other than what they were doing, they have to have the confidence in you to say, hey, listen, these changes are real. I know you don't think it's anything you're doing, but it's got to be something else. And repositioning this patient probably saved them from being plegic or quadriplegic in this case. This is the closing MEP data. You can see that there was no real correction of the kyphotic deformity, just a fusion across. So what about this checklist I keep talking about? So we have a checklist that was published, and I was part of this Delphi consensus report, where when you see changes in intraoperative monitoring during spine surgery, particularly in a stable spine, these are the kinds of things that have to happen. And I can't impress enough upon everybody that this gaining control of the room is incredibly important, right? So everybody has to stop and start thinking about exactly what's going on in that patient, right? And that means taking a pause, stopping the case, and announcing to the room that we're taking a surgical pause, eliminating extraneous noise, music, don't have people talking. The worst thing that can happen in these cases is, yelling at one another, et cetera, and summoning the attending anesthesiologist the senior neurologist, the neurophysiologist, into the room and making sure the entire competent, experienced team is there at one time. And then you move to anesthetic, systemic reasons, technical neurophysiological reasons, and surgical reasons. And then and only then you come to ongoing considerations in these cases. But it's incredibly important to, I mean, we have ORs where we have this hanging on the wall, this checklist, so that we make sure we run through these. And in the absence of a checklist, it can be chaos. And it can either be chaos or it can be that unfortunate scenario that I described earlier, where your recommendation to the surgical team is summarily dismissed as either being a technical problem or I wasn't doing anything. I mean, if you look at this case I just showed you, it's perfectly reasonable for the surgical surgeon to say to me, I wasn't doing anything. And my answer to them is, yeah, I know you weren't doing anything, but something's going on in this patient. So I think that's why the checklist is important. There's also in the same Delphi consensus is the best practices for intraoperative monitoring in deformity surgery. You know, again, these are things I listed at the beginning. It's best performed with a team approach. Surgeon, anesthesiologist, qualified neuromonitoring personnel should all be should all be involved in the identification and communication changes, et cetera, et cetera. So I can't stress that this is a model that needs to be used to most effectively utilize the intraoperative monitoring. Nishant, you can, if you want to stop me or whatever, just go ahead, but I'm just going to keep rolling if that's okay.
Yeah, please go ahead, sir. These are extremely interesting cases and very educative. Probably we can just quickly go to the take-home message of each case and then run through so that...
Perfect. I can give you as much time as you want. So, and I could talk all afternoon, so just stop me when you want to. Sure. So case 4, 44-year-old male presents to the ER as a non-restrained passenger in a motor vehicle accident versus a tree. In our instance, the trees typically win in these accidents. The motor vehicle does not win. He's awake, alert, oriented time 3, following commands bilateral and complaining of neck pain. So once again, you know, having a baseline neurological examination to my avail as a neurophysiologist is incredibly important, right? Because it sets the stage for my anticipation of what type of data I might get from this patient, right? Which is really important. You know, if this was awake, alert, oriented time 3, but not moving his left side, that's really going to set the stage for my anticipation of what I'm going to see in my data when I begin to record. So this is his spine. You can see he's got a what? Got a significant bilateral jump facet. Well, you can't tell from this, but his facet is jumped at 1, 2, 3, 4, 5. So bilateral 4, 5 jump facet, right foraminal fracture, neck pain. Otherwise, he's neurologically intact. He's a lucky guy because a lot of times in that scenario with that scan, they're not intact. So procedure: open reduction, anterior cervical discectomy, and internal fixation of the cervical spine. What I didn't show you was an MRI that was done. He also has a big disc at that level, and that's why they decided to go anteriorly. So reduce them from the front, do a discectomy, put a big graft in there, get a reduction. And we knew going in that if we could not reduce him from the front, they still wanted to do the disc, and we were going to flip him over and do him from behind and reduce them that way. You know, drill off the lateral masses and the facet and reduce them that way. Anyway, they only requested SSEPs in this case, not motor evoked potential. So, intraoperative surgical event. The surgery is essentially over, and they're doing some bone work and placing the plate. So the discectomy is done. And the SSEPs then begin to change in a very strange way. And this is where, as a neurophysiologist, understanding the patient's pathology, understanding the waveforms, and understanding the anatomy of where and how the waveforms are generated along the neural axis allows for interpretation of this data and allows for us to give the surgeon in this case very precise information about what's happening in the patient. So these are the ulnar nerve SSEPs, left arm, right arm, and subcortical or brainstem potential, left and right. what you can see is this is where we first started to see a change, right? Only in the left arm and only in the left brainstem, right? So, like I said, the surgery is essentially done. The reduction's been accomplished. They're putting a plate on. These are the tibial nerve SSCPs. And while they're changing some, they're not changing as demonstrably as the upper extremity SSCPs. And time is going from the top down. So we go back to the ulnars, and this is incredibly scary, right? So now the cortical SSCPs from the uppers are essentially gone. Interestingly, the left brainstem, probably cervical medullary junction SSCP is gone, but the right's still there. So I'm thinking, in my mind, mechanistically, how could a distraction or maybe a new distraction or something cause this type of strange change to occur? Because what we're looking at here is we are looking at supratentorial changes and only some infratentorial changes, right? So this brainstem change is only on one side, despite the fact that it's not on the other. Go back to the ulnars, and you can see the ulnars are starting to go away. They're getting smaller and smaller and smaller. So the question here is, obviously, we're going to tell the surgeon something was going on. So I tell the surgeon in this case what we were seeing. As I said, the case was essentially over. Why did the left ulnar go away completely and then the left tibial persist? So how do you get that? How does the ulnar go away and not the tibial in spine surgery, right? Those pathways are right next to one another. It's hard to anatomically rationalize in my mind how you could get that. So the question becomes, for me and for the surgeon, right, do I have a problem with this guy's spinal cord, right? Do I need to do something? Do I need to take that plate off? Do I need to check the graft? Do I need to bring fluoro in and make sure he's not off again, his cassette's not jumping? And the answer is, well, I'm not sure at this point, what I said. And so the question I said, well, MEPs have helped in this case, and I don't think they would. So what I did was I went over and I looked at the scan, and I looked at the pathology, and I opened the patient's chart. So what is one of the additional pathological features that's commonly seen with a bilateral jump facet and specifically a foraminal fracture? So this patient had and was taken to the operating room with a known vertebral artery dissection. And what they decided to do in this case was to fixate his spine before they addressed his vertebral artery dissection. So vertebral artery dissection or carotid artery dissection, secondary to flexion extension injuries in MDAs, are treated with what? Heparin, right? We heparinize these patients. Surgery did not want to heparinize this patient and take him to the operating room. So they decided to take him to the operating room, do the fixation, and then put him on heparin. And unfortunately, this guy died, never awoke. So what we were seeing in this data was embolic events coming from the vertebral up the basilar and picking off specific points in the brainstem. And that's why the data looks so strange and how it changed so strange. So at that point, my recommendation was to not re-explore the spine, was to get him off the table as quickly as possible, and to safely as possible, is get him on heparin. But unfortunately, the die was already cast in this guy, and he had succumbed to brainstem infarction that he did not recover from. But it did prevent re-exploration of the surgery and was a means by which to diagnose. The data allowed us to diagnose this problem on the table. Case 5 is a 62-year-old female with a history of stage 3 rectal cancer. She presented with bilateral upper extremity paresthesias and electrical shock sensation when she moved her neck, which is always a bad sign, right? So any clinical movements were exacerbating her symptoms. Otherwise, she was awake, alert, oriented times 3 and following commands. So you can see she's got a significant, what appears to be intramedullary mass in her cervical spine. So this could be, now remember, she has colorectal cancer. So this could be metastatic, this could be intramedullary, but clearly a expansile mass that is significantly impressing your cord. So this was diagnosed from scan as an intramedullary cervical lesion, and a differential diagnosis was metastases, glioma, or ependymoma. It would be really bad luck for somebody who has cervical cancer to also have an ependymoma, but that had to be put on the list. So the procedure was planned as a C3 to T2 laminectomy, midline myelotomy for resection of spinal cord tumor, possible fusion from C3 to T2, and the neuromonitoring that we provided in this case after speaking with the surgical team were SSEPs, transcranial motor evoked potentials, EEG, and D-wave monitor. What was the event? So the baseline SSEPs were all present but delayed. The MEPs were present bilaterally from the upper and lower extremities, which was quite frankly somewhat remarkable. Near the end of tumor resection, there was a decrease in the upper extremity muscle group, and it was a 50 to 80% decrease. So here's the baseline SSEP data. Beautiful left upper extremity, right upper extremity, beautiful left lower extremity, right lower extremity. Here's the MEP data from this case. So this is right trap, deltoid, biceps, flexor extensor, ATB, anterior tibialis, and AH, and the complementary muscle groups on the right side. So beautiful data to follow in this case. So we did do D-wave monitoring. I'll just touch on this for a second. So once the laminectomies were performed, we want to put our grid that has contacts on it, coddle to where they're going to be working, and we do record directly from the spinal cord. We record the D-wave or direct wave in response to single stimulation of single pulse transcranial stimulation. So here are D-waves, and you can see that they're repeating very nicely and coming in at the appropriate latency. So they do the myelotomy. There's no significant changes to SSEPs and TCMEPs. So it's really interesting. In my experience in 30 years, most people would say, well, as soon as you do the myelotomy and you go through the dorsal columns, you're going to lose your SSEPs. I would say that probably 60 to 70% of the time, if the myelotomy is done carefully, you don't lose the SSEPs. I worked with a pediatric neurosurgeon years ago who's since retired. His name was Leland Albright. And he always used to say, is to do a myelotomy, you don't have to cut the dorsal column, you can separate the dorsal column. And losing the SSEPs could not be an option in these cases. And he's right most of the time. Here are the motors, and here are the D-waves. So everything's looking really good in this case. So as I said, near the end of tumor resection, there was a decrease in the upper extremity muscle groups bilaterally. So the lowers are looking fine. ATB is looking good. So green is baseline, white is the most recent motor evoked potential. So hands are looking fine, legs are looking fine. But you can see the proximal muscle groups are changing. So, here's the paradox. I'm the neurophysiologist in this room, and I tell the surgeon this, and he goes, how can that possibly happen? I'm working inside the spinal cord, and you're telling me that somehow I'm affecting only the proximal muscle groups, but not the distal muscle groups, and the legs look fine. And so I think that rationalizing an explanation for something like this is really of the utmost importance, and also recognizing and asking the appropriate questions of the surgical team in this case. So the first question I ask is, where are you working? Well, they can say, I'm working in the court. What level are you working at, right? Which is really important. Because remember, in these cases, in intramedullary spinal cord tumor resection, you're not only working in the cord, but you're also working laterally to try to, for example, especially in an ependymoma, which sometimes does have a nice border, you're working laterally and anteriorly. So you could, in fact, be affecting some muscle groups and not other muscle groups, despite the fact that you're in a cord. So the alarm criteria here for us is a 50 to 80% decrease in alarm criteria. So if the surgeon said to me, how do you think this patient's going to wake up? Should I continue resecting tumors? I think that's a very legitimate question for the neurophysiologist. And I think the neurophysiologist has to have an answer for the surgeon at that. So we looked at the SSEPs and we looked at the D-waves, and the D-waves were beautiful. Never changed in this case. So, SSEP is unchanged from baseline. TCMAP still decreased in amplitude. The D wave response was present and unchanged. Never lost any amplitude of the D wave. So, I relied on the data that we know is published with regard to cervicothoracic, intramedullary spinal cord tumors and MEP and D wave monitoring that was published 15 years ago by Dr. Delitis and Dr. Epstein in New York. And what they showed definitively in those cases is that as long as you maintain the D wave, right, significant changes in MEPs, while are a reflection of the fact that something is changing, in almost every one of those patients, as long as the D wave persists with appropriate amplitude, those patients either wake up intact or wake up with transient deficits and ultimately recover from the deficits that they wake up with. And Fred Epstein published that for years. And what he used to counsel, and this is all about counseling your patient ahead of time. What he used to say to the patients were, if I start to see changes in MEPs and the D waves are persisting, that's my clue that I may be on the precipice of creating irreversible damage. So what he tended to do was stage his procedure. He would stop, come back, take more tumor, et cetera, but rarely had patients with permanent death. Nishant, do I have a couple minutes just to do a couple cranial cases?
Sir, we can do a couple of cranial cases.
So microvascular decompression, like I said, Peter hired me years ago. So we do a lot of these. We've written a tremendous amount about diagnostic accuracy of brainstem auditory evoked potentials, about hearing loss following these procedures. Our experience with microvascular decompression for hemifacial spasm is very broad. We've looked at which waves to monitor when you're doing microvascular decompression, the appropriate time to set the baseline, the empirical factors associated with brainstem auditory evoked potentials, the effects of Botox on your ability to record some of these potentials. So we've covered broadly microvascular decompression in the literature as well. So this is one of my favorite cases to present because it stumped me. And I rarely get stumped in the operating room about what's causing the change we see. I figured it out, but it took a little work. So 56-year-old female, long-standing history of left-sided hemifacial spasm. She denied any other symptoms except the spasm she had. So here's a high-resolution MRI showing compression of the facial nerve by probably AI in this case. So arterial compression, hemifacial spasm. Procedure was a left retromasculine cranie. Patients in a park bench position, Mayfield head holder. Ironically, we have so much changed how we do these procedures. We don't put patients in head holders anymore in Mayfield to do microvascular decompressions anymore. We put them in a horseshoe, and it works just great. And we also no longer use retractors on the cerebellum in these cases. We open the basal cistern, take a lot of CSF off. It allows the cerebellum to relax to the point of where you can work in the CP angle without putting a retractor on the cerebellum. Because what we found over the years was the culprit for hearing loss in these cases was the cerebellar retractor, because it used to cause stretch of the eighth nerve. Anyway, decompression of sensitive vessels, SSEPs, we did that for positioning of the patient, brainstem auditory evoked potentials, and EMG or lateral spread. So what was the operative event? So the decompression was essentially completed or about to be completed. There was felt had been placed between the vessel and the nerve, and the surgeon was inspecting the wound and was about to start drying up. What we saw was a significant change in the brainstem auditory evoked potential from the operative side, and it moved out and went down. So these three channels, this hump is the wave 5 of the brainstem auditory evoked potential. And what you can see is it's there, and it's the red arrow, it just goes away. Well, that's really unusual. Typically when a potential like that disappears that quickly, it's a vascular event, right? So oftentimes the labyrinthine artery can go into spasm, and you can see this. This is typically not a stress event of the nerve. This is something going on vascularly. So what I did at that point was I stopped and I stimulated the contralateral ear just to make sure we still had potential there. And the ABR was still present on the contralateral side. We went back to stimulating the ipsilateral ear and it was still gone. We then, several minutes later, went back to the contralateral ear and it was gone too. So now we have a complete bilateral loss of brainstem auditory evoked responses in a case that was essentially done. So I thought to myself, well, what could this be? Well, I mean, if you run through your differential diagnosis, what could cause a bilateral change in brainstem auditory evoked potentials when you're working only on the left side? So I'm thinking this is a brainstem event, right? I don't know what else could have caused it. So remember I said we were doing we were doing median nerve SSEPs for positioning. So I thought, aha, I'll check my median nerve SSEPs. So here they are, they look fine, At the same time that the ABR goes away, so do the median. So now, myself and the surgeon are in a panic. So now we think we do in fact have a big brainstem problem here, right? Why would bilateral brainstem auditory evoked potentials and bilateral median SSEP potentials go completely away? Well, obviously, you think about where these potentials are generated, where these pathways run, and they run through the brainstem, they run right through the pons at the level we're working. We're thinking worst case scenarios. So now the onus is for me to come up with explanations for why this occurred. And I can tell you, and my surgical colleagues who are on this call will appreciate this, the surgeon was not very patient at this point in terms of wanting an explanation for what was going on. So I looked around the room and I found that the scrub tech was a bit nervous. And I said, what's wrong? And she said, I didn't dilute the papaverin that I gave Dr. Gardner, and he squirted full strength papaverin on the brainstem. Well, I had no experience with why papaverin would do anything to the brainstem. But that went to the top of our list for what was going on physiologically in this case. So in the operating room, as our median started to come back, I did a PubMed search and I found this paper. Transient bilateral brainstem dysfunction caused by topical administration of papaverin. So it turns out that if you put too much papaverin or full strength papaverin on a vessel or on or about the region of the brainstem, and it trickles down and enough of it gets onto the brainstem proper, it literally puts the brainstem to sleep. And the brainstem can no longer conduct any information up and down. Turns out that the first author on this paper from Florida was attending at our place because she was a fellow when she was in Florida. So I called Colleen and I'm like, hey, I've got another tape for you to report about papaverin. So this is about the wherewithal of understanding what was going on, what the probability of there being a complete brainstem infarct in a case like this, and investigating all the things that can happen. So what do you do then? What do you do then is my recommendation was that we didn't, number one, extubate the patient, right? Because who knows whether they're going to support their airway. So we took the patient to the ICU, intubated. While they were intubated, we did a neuro exam. Their hearing was down in the left ear, and about 2 hours later, their hearing returned to baseline, and their hemifacial spasm was gone. So the operation was a success, despite the fact that we were beside ourselves trying to figure out why it looked like we had a bilateral brainstem infarction during this procedure. One more, Dushyant?
Sir, we can have one more.
Okay, I'm trying to decide whether to do the EEA case. Yeah, I'll do the EEA case because it's a really interesting case as well. So as with microvascular decompression, we have a very vast experience here with endovascular surgery, endonasal endovascular surgery, where we do everything through the nose and we take out tumors from the inferior skull base, tumors from the cavernous sinus, brainstem tumors, etc. We've written extensively about the utility of monitoring in these cases, SDP monitoring, EMG monitoring, cranial nerve 3, 4, and 6 monitoring, both in adults. We've also published in the pediatric literature looking at the value of lower cranial nerve monitoring, because you can actually get as low as C2 through the nose. So, where we used to do a lot of clival penises through a transoral approach, we can actually do them through the nose, and we can do the penis. We can actually do odontoidectomies through the nose as well. But obviously, the cranial nerve, lower cranial nerves, are put at rest. And we've also now published a paper a couple of years ago where we looked at why it's so valuable to do monitoring, because if and when you experience a carotid artery injury during these cases, the only way to know whether or not you can sacrifice that artery or you have to primarily repair that artery is if you're monitoring the case. So the monitoring acts essentially as a balloon occlusion test in the operating room. We've looked at 5, we've looked at every nerve you can think of, we've written about. So this is a 73-year-old female who presented to the neurosurgery clinic with a history including headaches, worse in the morning, loss of balance, left-sided hearing loss, difficulty swallowing, double vision, confusion. So you can see she's got a lot of brainstem issues ahead of time, right? So if and when you're going to do monitoring, you're going to tailor your monitoring not only around the regions that are at risk, but anticipation of, for example, not getting a left-sided brainstem auditory evoked potential, or potentially having some issues with the sensitivity and specificity of cranial nerve 9 and 10 and 12 in those cases. So here's her MRI. You can see she's got quite a big lesion. She's got a tremendous amount of compression of her brainstem, and the radiology report is that the extraaxial mass extends anterior along the entire clivus, creating severe compression of the brainstem and posterior laterally to the right. Encasement of the basilar artery, extension into the sella thursica, and the left cavernous sinus. So in reading this, I'm formulating my neurophysiology approach to what I'm going to monitor in this case. So obviously monitoring brainstem function and monitoring cranial nerve function in this case, I think, is of the utmost importance. So the decision was made to proceed with a transclival EEA approach. So the approach is going to be through the clivus. The surgeon requested, upon conference with us, SCPs, transcranial motor evoked potentials, brainstem auditory evoked potentials, and we also did cranial nerve 6 and lower cranial nerves in this case. We did 6 because there was tumor in the cavernous sinus. Beautiful data from an older patient. Left and right SCP, left and right lower extremity SCP, wave 5 of the brainstem auditory evoked potential, and nice motor evoked potential. So hours into the case, while taking posterior tumor capsule, there was a unilateral loss of amplitude from the right body TCMEPs and a threshold increase. So left MEPs in the right hand and right leg look fine. And there's this loss, subtle loss, if you will, of the right anterior tibialis. But we thought enough of it to make the call. Why did we not, as neurophysiologists, ignore this? Because, look, the AH is still there, the ATIB is gone, right? So you could, at least I could, you could convince yourself to say, let's wait and see, and let's not say anything now. So there was never a complete loss of the upper extremity TCMEP, but the lower extremity TCMEP eventually became absent. And we told him about this here. But when the upper extremity started to change again, green is baseline. So we still have an small upper extremity MEP, and we have lots of lower extremity MEPs. The SCP and brainstem auditory evoked potential remain on baseline. So again, this is a intraoperative consultation, and this is a case where the surgical team has the confidence in the monitoring team, both with regard to the consultation that's being provided and the interpretation and diagnostic accuracy of the data. So what did we decide to do? So in the face of a unilateral worsening change, we decided to abort the procedure before all of the tumor could be resected. This patient awoke from surgery with flaccid paralysis of the entire right side of their body. Post-op MRI shows injury to a pontine perforator that resulted in a small infarct in the left medial superior pons. So this makes sense, right? This was not a perturbation of brainstem parenchyma, right? This was a vascular injury, right? Which I'll show you in a second makes complete sense. So as I said, we stopped the resection. The patient awoke like this. But what you can see in the post-op MRI is this is exactly where the corticospinal tract is. And you can see this small infarct from the pontine perforator that occurred. So we had a discussion in the operating room with the surgeon. I had a discussion that I thought that this was a vascular injury. It could not be taken back. And to continue with the surgery could only result in worsening of her deficit. So 3 years out, despite the fact that she woke up with a devastating injury, she actually has some movement of her hand intrinsic and bicep. So she's regained some function of her upper extremity. So once again, this is a case where at face value, you say, well, what did the monitoring do in this case? Well, the monitoring identified exquisitely exactly what the problem was in this case, right? And upon conferring with the surgical team, the decision was made to stop at that point and not cause any more damage to this patient. And it proved to be the right idea. And again, you can just see, this is the pontine perforator. This is where the corticospinal tract is. And if you look at her MRI, it's exactly tells the story of not only what was the problem, but how she was going to wake up. So it really exemplifies the importance of the surgeon actually using the intraoperative monitoring that was requested. Fortunately, as I started off saying, this particular surgeon also understands the intraoperative monitoring exquisitely. He also knows that I understand the brainstem anatomy and physiology and vasculature. And so when we have that discussion, it is a collegial discussion that happens in real time, and decision making is made about what's going to happen. I'm gonna stop there, Nishant. I just want to say,
yeah, we can stop there.
One thing is, I'm trying to find this slide. Oh, just want to put this. So just to exemplify the relationship that we have with our neurosurgeons at UPMC. This is a quote from one of our chief of cerebral vascular surgery here. And he says, it's just great to have a neurophysiology team that isn't just floating in the background. And you guys know what that means, right? He says, I'm definitely a better surgeon as a result of your intraoperative consultation. And that really is the take-home message of this entire presentation, right? You can't just float in the background. You've got to be part of the team. You've got to be a trusted part of the team. You've got to endear yourself to the surgical team that lets them know that you can walk the walk and talk the talk, and that you understand what they're doing and they understand what you're doing. And as a consequence of that, I can guarantee you that your patients will be taken care of at a much, much higher level. Thanks very much for your attention.
Thank you very much, sir. The cases were like a roller coaster ride. I mean, we could relive those moments as you were describing those cases. So it's open for discussion now. So, and I must say that we have had about 90 live users right now. So
okay,
that's really great. And yeah, to the audience, so some of the points that Professor Balzer emphasized is that it's not just enough for us, to place electrodes, work with the software. We have to know the steps of the surgery and the individual patterns of doing the surgery of various surgeons. So each one will have a particular approach. So we have to be with the team, and we also have to have an understanding of what the anesthesia is there at the background. So one case that you really emphasized well is that you had a case where anesthetist is saying it could be because of gases, but because of the you could very clearly recognize the pattern of change. You said no, it's not anesthesia, but it's actually something that's happening at the surgeon, and the surgeon also pays due respect to your words and then changing his approach. So these are the things that have to happen to build that trust. So the confidence competency loop will keep improving as you keep giving these kind of suggestions. So yeah,
I think I can speak on behalf of the surgical perspective. I think the onus is on the neuromonitoring team to make sure that the surgeons do trust them, right? And you do in fact have to be able to have those high level discussions about what was going on during the procedure. And what I always say is, my interpretation is my interpretation. Am I going to make mistakes? Perhaps, yes. But you have to stick by what you think is going on, and you have to base that on your experience, your understanding of the data, your understanding of the literature, right, with regards to what you're collecting, and your understanding of the surgical procedure itself. I think those are really important. The one thing you touched on and you glossed over very quickly is the other thing that's a major thing in this field is every surgeon is different, right? So gaining experience with the flow of the surgery,
yes,
how the surgeon wants to hear things, when the surgeon wants to hear things. There's not one recipe that works for every surgeon and every procedure. So it's also our responsibility to have insight into who we're working with, what they're doing, what the complexity of the procedure is, because how that intraoperative consultation occurs in each of those different situations may not be exactly the same. And for it to be effective, we do in fact need to modify it based on who we're talking to and who we're working with.
Sir, Professor Suresh Babu sir, your comments, sir.
He's muted.
You are muted, sir. You are muted, sir.
We are very thankful, Dr. Balsar, for your very informative case scenarios. We learned a lot from your talk. There's no doubt that the presence of a neurophysiologist makes the surgeon a better surgeon. There's no doubt. I keep telling Nishant and my colleagues that because our techniques have improved. When we operate on cerebral pontine angle tumors, when we try to dissect the facial nerve, we now know which movement we should avoid, which movement is permitted during the procedure. So also now in cervical spondylotic myelopathy, we know the technique we should follow to get a good outcome. There's no doubt about the value of neurophysiologists. Today I learned definitely about this papaverine. We have had a few patients after aneurysm surgery. Putting papaverine at the end of the aneurysm surgery is very common. We put on to prevent vasospasm. And then we have seen patients waking up fully conscious, but pupil is not reacting to light, but it reverses after some time. We have seen that. But I have not heard of this. I have missed the articles saying that papaverine can cause brainstem dysfunction. Retrospectively, I think we can recollect. Sometimes now we have had patients, surgery was good. At the end of the surgery and even cerebral pontine angle surgery, we have put papaverine. But I think we should avoid that because of what you have told. You have shown the harmful effect of papaverine, though it is only short-lived. I have one question to ask. in two of your cases which you showed, you had you did monitoring of only by SSEP and not MEP. For that spondyloptosis cases, you did not do MEP and you did not monitor the sphincters. You did not do bulbocavernous reflex. Why is it like that? So also the trauma patient, cervical spine trauma, you have done only SSCP. Is there any protocol to avoid MEP?
That's a great question, and so we have a protocol, and our protocol is exactly what you just described. It would have been SCPs, MEPs, BCR, and anal sphincter EMG. We also work with surgeons who are, and you can understand this, who are somewhat set in their ways about what they do and don't want monitoring. So what we do in those cases is we offer what we have in our policy and procedure manual, right? And what we recommend for a good reason, right? There's data to support it. If the surgeon declines that, then they decline it. So bottom line is, while I agree with you that those modalities would have been potentially helpful, that we ultimately leave the decision up to the surgeon or surgical team as to what they want to monitor. I do want to make, if I could, one comment on what you originally said when you spoke, and I can't stress it enough. You know, we talk about changes in monitoring as guiding surgery and helping the patient. But oftentimes, and this is very, very hard to index and is not written about at all, no changes in monitoring also guides the surgery to a great extent as well. So for example, if you're retracting on something or you're putting a cage in, and how often is it if you look over at the monitoring team and say, how do things look? Do you see any changes? And if you're told there's no changes, then you continue with maybe a bigger cage or retracting on something. So the success of a lot of procedures are predicated on there not being changes in the intraoperative monitoring, not the fact that we're looking for them. And I think that's a very valid point.
Yes.
Yeah, we have Dr. Vishwa also. Vishwaraj, would you like to highlight some?
That was really a fantastic talk. So, I mean, I'm a neurosurgeon, and along with Dr. Suresh Babu, we work together. And my interest is mainly in endoscopy. I just wanted to know, being in the forefront, what do you think is the role of VEP or have you experimented with VEP in endoscopic pituitary surgeries, and have you tried to prognosticate it to find out whether we can find out the optic nerve chiasm and compression and whether it can be reversed? Do you have any comments on that? VEP?
I do. Great question, and a very timely question, right? So as you suggest, when you do EEA surgery, oftentimes it's done for patients with, for example, apoplexy, worsening vision, et cetera, et cetera, et cetera. And a lot of these big lesions, you know, are right at the horizontal segment of the carotid and at the chiasm, right? So we began exploring doing visual evoked potentials in those cases. But here's the problem. If you remember at the beginning of my talk, what I said was, I don't want to disseminate information that I don't know what it means. So for example, if we were doing VEPs and I looked at the surgeon and said, hey, the visual evoked potentials are down by 50% in amplitude, you should look at me and say, what does that mean, Dr. Balter? And I'm going to say, I have no idea what that means, because we haven't indexed it. So what we're doing, and I hope to have an answer for you in 6 or 8 months, is we are in fact monitoring those cases now, particularly the patients who come in with decreased visual acuity. And we're looking for, as you suggest, how the visuals change with decompression. So what we're trying to do is we are in fact trying to characterize what a change in the VEP means by simply recording them in all those patients. We're not intervening based on the VEP changes. It's an information gathering thing. So we're going to do the VEPs, then we're going to go back at the end of the procedure and look at their preoperative neurological visual status and their postoperative neurological status. the really visual status. And the nice part about the study, with all due humility, the nice part about the study is we're getting formal visual fields pre and post-op. So we have objective measures of visual acuity pre and post-op that we can base the DEP changes on. Great question. Great question.
So
that would be really interesting.
Yeah.
In fact, Nishant can comment. We attempted in 2 or 3 cases, and Nishant can probably.
Yeah, my response was similar to what Professor Balsar said. So we have recorded, we have documented changes, but the literature, the predictive value of changes, the literature is not very robust. So we are also doing some kind of an observational study with respect to VEPs.
I think you have to crawl before you run, right? You have to have that data, and I always like to use the word mature. I don't think the literature has matured to give us an answer to that question. The other problem, getting back to your original point, Doctor, is that when you're doing an EEA, you're working here, lots of stuff in the field, lots of hands on the face, and you've got these goggles. Or the delivery of an appropriate stimulus is really difficult to do, particularly if you're also doing oculomotor EMG, right? So now you've got needle electrodes in 3, 4, and 6, and you're trying to. So we've tried a bunch of different stuff. We've tried those little sticky diodes that you can put on the lens. We've tried that big thing. I forget who commercially makes it. Looks like ski goggles because it allows you to do 3, 4, and 6. So it's as much a technical challenge as it is an interpretive challenge.
We have Professor Muthukumar. We do a lot of cases, detethering cases. Professor Muthukumar is one of the experts in detethering surgeries, and he also does a lot of cervical spine cases. So in a couple of cases with Professor Muthukumar, we have noted that there is a change, significant change in compressive myelopathies, cervical myelopathies. The signals are only about 10 to 20% of baseline. We also record D wave. We show that D waves are recordable, but we must remember that we don't have a baseline in decompressive myelopathies,
right? Because
we put D wave only after the decompression. So in these cases, what we have consistently noted in a few cases is that signal, the last check is only 10 to 20%, but we demonstrate that pattern of recovery, a pattern of reversibility, and by the time the surgery is over, the last stitch is taken, patient is extubated, the power is almost back. So here, surgeon has all the rights to suspect that it is a false positive call, but electrophysiologically, what's happening is we are identifying an ongoing damage. The surgeon is also incorporating into his steps, taking the necessary steps and not doing further damage, and it's actually improving. So in these kind of special scenarios, would you still call it a false positive, or have you come across these scenarios?
No, Nishant, that's a great question, right? Because the problem we have with intraoperative monitoring and describing its utility is that what we're oftentimes left with in doing a retrospective analysis is we're left with looking at whether or not there was a change and looking at how the patient woke up, right? And so if you look at transient changes and a patient waking up fine, that's going to be scored, if you will, as a false positive every time. If you don't have retrospective information along with that there was an intervention or that you did something, then it has to be considered a false positive, right? So what are some cases where that's not the case? So we've published extensively on carotid endarterectomy, right? We know that you cross-clamp a carotid. If we see a significant change, surgeon puts a shunt in, the responses come back to baseline, and the patient wakes up fine. Would anybody call that a false positive, despite the fact that it was a transient change and the patient woke up, there was a significant change and the patient woke up fine? No, we would never call that, because we have a definitive therapeutic intervention that we can point to that was responsible for the patient waking up fine. So what we're doing now in a subset of cervical surgery, as a matter of fact, is we have a prospective, not a checklist, but almost like a diary of when we tell the surgeon that there's a change, what do they do or what don't they do? So at the beginning of my presentation, I showed you that paper that it was a multi-center analysis that was done by Jim Harrop at TJ, Bill Welch at Penn, and Bob Reed down at Emory, where they looked at changes in motor evoked potentials and deltoid palsy, C5 nerve root palsy. What they did in that paper is they prospectively asked the surgeon whether or not they were releasing traction on the nerve root in response to the MET change. And they wrote that down. If they hadn't written any of that down, you're left with a bunch of false positives, right? Because you don't know what happened during the case. So that's a great question. And it's a problem because of the way we collect data. Listen, I've been doing this a long time. We have not done a good job of describing the utility of intraoperative monitoring in these procedures, right? Because what we haven't done is we haven't talked about the detail of what's done in response to a significant change. As Suresh pointed out, a lot of what he does is being guided by what you're telling him, but you're not writing any of that down, right? You know he's doing that. He knows he's doing that. But to index that is very, very difficult unless you have something in place prospectively to record that data. And I think that's what we have to do as a field. And but that's a great question as well.
Thank you, sir. Thank you so much. Yeah, if there aren't any more questions, I think it's been over.
It's almost 2 hours.
Yeah, almost 2 hours. So we'll call it a day, night here. So thank you so much, sir. Thank you so much.
My pleasure. It was an honor to be invited. It truly was. I'd be happy to do it again. I'd be happier to do it in person. So if we can find a time and a reasonable time, I'd love to visit you guys.
Yeah,
you should invite Dr. Balzer again. Maybe next month or 2 months later, we should invite him again.
sure.
Yes, I think we listened only some 25% of the material he wanted to talk because of the time constraint. We have to cut down. We should invite him again, Nishant.
Yeah, sir. Yeah. And yeah, sir. Thank you so much. And
My pleasure.
yeah, and
Everyone have a nice weekend.
thank you, sir. Thank you. Thank you so much.
Take care.
Yeah. Yeah, sir. We'll